Good afternoon, everyone. I thank organizers and I thank AstraZeneca for giving me this opportunity today. So what I've been doing is quickly talking about the real world experience. We have seen the FLORA data. We have seen a clear improvement in PFS, 10.8 months going to 18.9 months. All subgroups benefiting with osimertinib over the first generation TKI. Next, please. We also saw the updated overall survival analysis, which a few years back, again, clear improvement in overall survival, 31 months going to 38.6 months, hazards of 0.799. And with this, osimertinib got accepted throughout the world as a first-line agent, which could be the ideal first-line therapy, and most of the oncologists all around the world are using osimertinib as first-line. Next, please. But there's always this question about next, please. We've seen this in all our NCCN guidelines, and all the guidelines have put it as preferred regime for first line. But what is there's always this talk about whenever you have clinical trials, you have a patient population whose only performance status is good, they're 0 to 1, they're very controlled trial settings. So what happens to your patients in the real world setting? And these are some real world evidence which we have seen recently of osimertinib, and we'll just talk quickly about 3 of them. Next, please. So this is the FLOWER study. This is coming out of Italy. It is a prospective study. Next, please. So this is coming out of Italy, where they were looking at patients who received first-line osimertinib. It was about a 1-year duration where all the patients who received osimertinib were followed up prospectively. There were about 126 patients who received first-line osimertinib. So about 30% of patients had brain metastasis, and there were both the kind of EGFR mutations were available in this group of patients. Next, please. The primary endpoint was looking at time to treatment discontinuation. So the whole thought was, whenever you give TKIs as first line, there are many patients who have oligoprogression, and you tend to continue the treatment with TKI. You may add just some local therapy, some radiation, and still continue your first line TKI. So just looking at PFS may not be the only factor. So the thought was, let's look at time to treatment discontinuation. And what they saw was the median time to treatment discontinuation in this study was 25.3 months. Now, they also looked at some stratification factors, and they saw that patients who had no symptoms versus symptoms, the time to discontinuation was much more for patients. It was delayed much more for patients who did not have symptoms. Also, patients with less than 3 metastatic sites, again, the discontinuation was much later. It was not reached versus 21.4 months. Next slide. The median progression-free survival was 18.9 months. And again, they looked at some subgroups. Patients with brain metastasis, it was about 13.3 months versus not reached without brain metastasis. And again, patients with and without symptoms, the patients without symptoms had a much better PFS. Next, please. They also looked at some diagnostic therapeutic pathway. How much time does it take for each of the things? It took from biopsy to getting a patho report of 7 days, from the path report to the EGFR mutation 8 days, and from starting of osimertinib for about 17 days. So this is something that we all see in real world practices. This is how much time it takes for most of our patients to start off osimertinib. The patients who progressed, about 47% of patients had a rebiopsy, about 66% had tissue rebiopsy, 28% had liquid rebiopsy. And again, some patients found that there was some driver mutation which could be treated at progression. There was MET amplification, there was EGFR and HER2 in some patients. Again, this is something like what happens in real practice. Next, please. The most common side effects: diarrhea, stomatitis, dry skin, rash. These were the main common side effects which you saw. But if you look at the grade 3 and 4 adverse events, the most common one was venous thromboembolism, and there was some amount of ILD. The VTE was about 7.9% in this group of patients, and ILD was seen in about 2.4% of patients. There was no difference in the rate of VTE in relation to any of the other factors. So eventually, the authors concluded there is no difference in survival outcome with osimertinib as first line according to age, comorbidity, and type of EGFR mutation, and it confirmed the effectiveness and safety of osimertinib as first line study in the real world setting. Next, please. So the next study is the OSIFACT study. Now, next, please. This is coming out of Japan, where they were looking at retrospectively of a patient population between 1.5 years of treatment of timing of patients who had received osimertinib as first line therapy. A big study, patients number was 538. Again, brain metastasis in this group was about 30% of patients. Next, please. So what they saw, the PFS for this study, 20.5 months was the median PFS. So almost the same or slightly better numerically if you look at it from the FLORA data. Next, please. And they also did a multivariate analysis to see whether PFS mattered in subgroups or not. And what they said, the males performed poorly, patients who had malignant effusions performed poorly, patients with liver metastasis performed poorly. There was a difference in such group of patients. And they also had analysis where they looked at PDL1, and about 60% of patients, they were able to do the PDL1 testing. And what they saw, the PDL1 patients who were positive, more than 50% and more than 1 to 49% of patients actually fared worse. Next, please. 219 patients discontinued treatment in their study. And what they saw, they analyzed why did they discontinue treatment. Now, here's it's very interesting. 44% of patients discontinued because of progressive disease. 25.6% of patients progressed due to pneumonitis, and 16% progressed due to other side effects. Now, this number of 25% is very large among the discontinuation rates, but this is something that you have seen from most of the studies with osimertinib and the Japanese population. They tend to have more pneumonitis, and this is something which is coming out of all the osimertinib data from Japan. And that's the reason why they had a 25% discontinuation due to pneumonitis. Next, please. So their conclusion, the authors said, overall response rate was 76%, disease control rate was 94%. Clearly, patients were responding well. This was almost as similar as what we saw from the FLORA data. The PFS was better with osimertinib. Again, it's almost the same, I would say. Numerically, it's slightly better than the FLORA data. The time to treatment failure was 19.1 months. Pneumonitis was the main side effect, which was worrisome, 12.8%. And they did say they would have to look at why pneumonitis is so high and why it was causing so much discontinuation. But this is not what we see from the other real world studies and also our Indian experience with we don't see that high pneumonitis due to osimertinib. Next, please. The last study is coming out of US. This is again a real world study. Next, please. This is a study looking at it's an observational cohort study. It is running in different countries, but this data set was coming out from the US, where they were looking at the electronic health records and they were using the Flatiron data. And looking at this, they looked at all patients who received osimertinib as first-line therapy between April 1 to 2018 to March 31st, 2020, and analyzed this. Next, please. So they looked at the clinical parameters, the demographic parameters, and treatment patterns. And they had a different kind of an endpoint. Their endpoints were two. They were looking at real-world time to treatment discontinuation as one endpoint, and the second endpoint was real-world time to next treatment or death. They kind of say that, again, the same thought comes in, just PFS per se is not really a good endpoint because of oligoprogression, continuation beyond progression, and you tend to continue the drug, especially in osimertinib and TKI therapy in lung cancer, quite a long time using local therapies. So the thought was looking at time, when did you really discontinue the drug, maybe looking at a good parameter as an endpoint. Now, next, please. So this is how they analyze their treatment sequencing. So a very nice diagram. They're saying they started off with first-line osimertinib in 548 patients. Now, 318 patients, that's 58% patients remained on osimertinib first line, or some population were lost to follow-up, but these were the patients who continued treatment, most of them. 103 patients, that 18.8% patients progressed and received second-line therapy. And then they looked at each of the second-line therapies. Some were PDL1 based, some were combination with EGFR TKIs, some were adding VEGF TKIs, and some of them went to chemotherapy. Now, about 101 patients, that's 18% patients died while on first-line therapy, and about 4.7% patients discontinued first-line therapy. Next, please. So this was the real-world time to next treatment or death. The median was 17.9 months, and this kind of shows us almost the same thing as we saw what our earlier studies were showing, and what our PFS comes out with the FLORA study. Next, please. There were some multivariate analysis, again, looking at subgroups. They kind of thought that stage at initial diagnosis, smoking status, the Charlson comorbidity index, the EGFR mutation type, and the number of metastatic sites were playing a part in this analysis. But again, it's very difficult to usually use these subgroups as a parameter, especially in this kind of a setting where you're putting all the real world evidence. Next, please. They also saw the real world time to treatment discontinuation, and again, it came down to about 17.2 months. Next, please. Next, please. Next, yeah. So, just one slide up. There was a, yeah. Okay, so next, please. Yeah, that's fine. So, the take home message is this study provides real world insights on the use of first line osimertinib in advanced EGFR mutated patients. The interim endpoint results, they support the effectiveness of osimertinib in the real world population, and they did conclude long-term outcomes will be evaluated in the final analysis, especially trying to see whether overall survival is better or not. So I would like to conclude with this. So there is a lot of importance to real world studies nowadays, and there's a lot of real world evidence coming out for all the new drugs you see real world evidence coming out these days, because that's how the patients present to us in clinics. So I think these are interesting studies which show osimertinib doing as well as what it did in the FLORA studies. Thank you very much. Thank you.